My topic today is shoulder pain from anatomy to evidence, because it's a new subject about how to make an analgesia, anesthesia for shoulder surgery, and it's become a common subject, especially with aging of the people. People now live for a long time, and the case for rotator cuff and degenerative shoulder increase more and more. So this is my beautiful city in Ras Al Bar. I invited everyone to visit it one day. There's another pictures. I don't have any conflict of interest or any support from any society or company or anything. So my agenda today, first thing I will speak shortly about introduction about shoulder surgery and causes. I will speak about history of regional anesthesia or anesthesia for shoulder surgery. And also I will just trigger the update anatomy, because the anatomy we study in university is not right 100%. Now we know that there is some variation in some structure up to 50%. So it's not fixed for everyone. So the fixed sign of anatomy we study in university is not fixed, and revised again, and we discover a lot about it. So I will speak also about some update about regional anesthesia modalities and new invention for shoulder surgery. I give you some methods about shoulder anesthesia and analgesia, what is the effect and side effect, how to use, how to treat if you get any problems. And I just will give you a simple hint about the evidence about regional anesthesia and the home message at the end. I know it is like a camel, and I must eat it. I don't know which time, but 40 minutes is not enough just to eat all this camel, but I will try as possible as I can. Sorry. As possible as I can to discuss it in this few minutes. So my learning objective after this presentation, you must have in your mind a plan to make an intraoperative and post-operative planning for shoulder surgery. And to make a safety perform of regional anesthesia for shoulder surgery, but you need some training, not just a lecture to make you like this, but this starting thinking about how to make anesthesia. To know complication of different methods, and to tailor the anesthesia upon the patient, because the procedure different from one-to-one, patient different from one-to-one, and even the procedure and even the anesthesia skills and even surgical skills. And to update your knowledge about anatomy, a new alternative block for intrascalene, because it's a gold standard for the case. Before going, I will just tell you about the shoulder surgery. Shoulder surgery is one of the most severe post-operative pain. And regional anesthesia can provide anesthesia and analgesia or both, or just maybe combined with regional anesthesia. And whatever regional or general is not important. The most important is there is a bigger problem for us here. It may be the pitch shear and compromise hemodynamic for the patient and cerebral function. So regional anesthesia may be an alternative for general anesthesia, and they can decrease in this effect. But for regional anesthesia, you must have a program. It is not just to bring a patient to put a needle in his shoulder and it works. It must have what's called patient education. This is the regional anesthesia not suitable for all patient. He must be educated, know everything, and to give him the expectation for regional anesthesia and the complication for it. And you must plan also, this is a part of multimodal, is a concept accepted everywhere. But before going, as every time we speak about the pain and what's the definition of the pain, I will not speak about it, because after 40 years, they bring another definition. He give unpleasant sensory or emotional experience associated with or resembling the associated with. They put this word. And I think this gives more confusion for the definition of pain. But I think pain definition is more easy to can see from this. This bread looks like a sad or enough pain. And even this barrel with one eye looks like happy. So the definition may be from internal. I hurt, I feel pain, I'm not happy about it. So mostly the pain in post-operative pain or just in intraoperative pain is a subjective sensation. You can't measure it like blood pressure, like temperature. And usually pain underestimated because you don't see it, you don't feel it, so you underestimate it. And because you underestimate the pain, you undertreat the pain. And this is a very bad influence for the patient and for community, for resources, for everything. And the problem with pain, what we know and what we don't know about pain is like we know like a tip of iceberg. And sorry, this is not a tip of iceberg. This is just a plastic bag. So now, pain management is a human right. It's not a privilege. You can give it for someone and to prevent it for someone. And you can go for what's called in the court for claim that you don't treat me in the right way for this pain. And we know all the time with surgery and the trauma, we have a severe pain because the process of pain as a basic, as you know, inflammatory mediator triggers the nerve and give us severe pain. Whatever you use in your anesthesia, whatever you use, right or left, whatever you use, you must thinking seriously about two things. Whatever you use in regional anesthesia, general anesthesia, safety is paramount. And don't try anything in a stressful time and don't master it. Whatever you master it, do it. And the debate between regional anesthesia and general anesthesia will stay forever because no black and white in our field. And the gray zone is a very big zone. So everything have an advantage and disadvantage. So the most important to us to get a smooth recovery for our patient and to discharge to recovery and to his home in a good way, in a safe way. So what is the goal of analgesia for shoulder surgery or for medicine? To improve the post-operative outcome. Because, you know, as we say in life, no gain, no pain is not right for pain management. Because if you have pain, you will not gain anything. You will lose everything. And to decrease the post-operative pain and related complication, all the organs in the body can be affected by this complication. From the heart, lung, GIT, everything can be affected. So treating the patient pain just can treat all this organ. And to prevent peripheral and central sensitization and to prevent what's called persistent post-operative pain, because this is a very big subject, and around 20 to 30% from the patient coming to my clinic because this persistent post-operative pain. He make an operation and still for many years complaining about his pain. And also to decrease the drug-seeking behavior. Don't rely on narcotics all the time, and the patient become addict because he's starting his addiction and he don't know anything about that. So the concept of multimodal approach become accepted now. Just many drugs with a small dose and can get a better effect, low side effect, and can control even the persistent post-operative pain, like pharmacological method like hot fomentation or cold fomentation, or just what's called massaging, opioid. And the role is decreasing a lot every day because the concept of non-opioid analgesia or opioid-free anesthesia or opioid-less anesthesia, regional anesthesia take a major part now because now with training we can make a many blocks for many areas. Paracetamol, non-steroidal anti-inflammatory, adjuvant like lidocaine, like dexamethasone, as Dr. Yasser said, ketamine can be used, lidocaine infusion, many drugs can be used for multimodal approach. So now going to the shoulder. Why the shoulder is one of the most important joint of the body? Because he make a very big range of movement, rotation, up, down, not like any other joint. And most of the time we get like minor trauma, and minor trauma lead to healing of this structure again. But because, you know, this muscle rotator cuff is squeezed under the acromio-coracoid ligament and squeezed area, low blood supply, usually we get a rotator cuff or inflammation, tendinosis. And many times we get a trauma, but trauma is not a very, the first common cause for this shoulder pain. So mostly we get a patient referred, and most of the patient is very old patient referred from the clinic, and we get some trauma, but trauma maybe the third cause. But most of the patient, when you get more older, he get more pain. For example, I will just give a statistic. So trauma is an important cause, but not the first cause for coming to the emergency and come to our surgery. And this is have a very important implication because usually trauma is young man and don't have a comorbidity, but most of our patient is old and they have many comorbidity. And most common cause is repetitive movement, and this is lead to tendinosis or degenerative disease or arthritis or many other avulsion disease for the joint. And many of this patient need an surgery. So shoulder pain is around the clinic about 7%. In older patient above 70 is 26, in above 80 is about 50% of the people complaining of the shoulder pain. About half of this patient may need a surgery, usually moderate to severe, not mild, and shoulder surgery is one of the most painful procedure you can see. So why is this very painful like this? Because most of the time the pain in post-operative become acute on top of chronic pain. Because most of the time this pain have a central sensitization, is chronic, and chronicity is different from acute pain. Acute pain is a sign or symptoms for disease, but chronic pain disease by itself and have a memory. So to treat a chronic pain is more difficult to treat an acute pain. And second thing, if you have acute on top of chronic, is more difficult to treat it. So this paper evidence that central sensitization is present with patient with shoulder impairment syndrome and influencing the outcome after surgery. And that the conclusion of this study just saying central and the peripheral sensitization negatively affecting the outcome and increase the pain severity and the chronicity, because also most of our patient is a chronic disease, not just a trauma. All the time, don't forget that shoulder pain may come from other area and deferred pain, and sometimes the cause of this pain is very dangerous. And I got a patient in my clinic for the orthopedician that the patient have a shoulder pain, and when I examined him, I found the patient in getting cardiac acute coronary syndrome. I send them make a stent after 2 hours. So sometimes if you make a good history, you can save your patient. So you can get a gallbladder disease even post-operatively. Internal hemorrhage and ectopic pregnancy can give you a shoulder pain, severe shoulder pain, referred heart pain in left shoulder, fibromyalgia rheumatica, and many other referrer. And you have a common referrer and less referrer. And we remember this was the common pain referrer came from the shoulder pain is with blast injury. And you remember this picture when he took his hand and make a like extension of the shoulder and get a fractured clavicle. And Mo Salah was crying, not just because he come out from the match, but because of the pain also. So blast injury can give a shoulder pain, fracture humerus, rupture muscle or tendons, radicular neck pain. Even radicular neck pain can just refer to the shoulder, thoracic outlet syndrome, diaphragmatic irritation from the gas from the laparoscopic surgery, and the river pathology. But soon, if you treat it in a good way, he's crying here, he become good soon. And also if you make a good analgesia for him. So there's many common diseases for surgery, but trauma come the third cause, inflammatory arthritis, osteoarthritis, post-traumatic arthritis, many rotator cuff is most common, osteonecrosis, infection is less common. But first, before just to speak for anesthesia, there is a many dangerous thing around this history of the anesthesia, which is general or regional. I don't care. Whatever you master, you can do it. But you can improve your skill to know the two. If you know regional anesthesia, you can learn to make a regional anesthesia and vice versa. But the most important for us here, many other things, and really big thing about the outcome. So I think sitting position is one of the worst things about this patient. And he can give a cerebral and spinal ischemia and thrombotic event and adverse neurological outcome. So we're thinking seriously about to make a regional anesthesia. If you can make a regional anesthesia, you can avoid some of this complication. Also, there's other complication if you have unprofessional surgeon or uncooperative surgeon. This is another problem. The third problem, if you don't have an cooperative patient for regional anesthesia and he don't learn how to get a regional anesthesia. And the third or fourth complication, we are working now in COVID, and COVID looks like will stay forever. So there is a more important problem than the analgesia or anesthesia. So before history, I don't know how can we make this surgery, because I remember my dad tell me that my grandpa get an amputation above knee and without anesthesia in 40s. And I don't imagine how can make this anesthesia. And the surgeon make it in 10 minutes. And my grandpa died after 6 years from this operation. But I don't know how can you feel and how can you do an operation like this. But the history started in 1984 it may be before that, but this is what's recorded about the first anesthesia. But what about the regional anesthesia for shoulder surgery? What about the history? The history started by innovation or creation of cocaine. first time from some plant from the India and the Far East. And it was used for everything, toothpaste, even with cough medication, even with wine. And I was thinking that is a very innocent drug, but it's not an innocent drug. In 1902, George Carroll described an open brachial plexus. I don't know how can he open. He opened and he put the medication inside, but how can he open without anesthesia? I don't know. In 1925, first percutaneous successful broke by Etnal. And this was the first one just to open the gate for Winnie after that in landmark interscalene technique in 1970. And he gave him the name unilateral spinal anesthesia of the upper limb. And it was, the ultrasound came after that, and nerve simulator, and make an regional anesthesia more and more widespread. So the history started really with Winnie. It was landmark technique and high volume. If you remember, 30 to 40 mil, and I think now if I do that, it will killing, but it will do the brachial plexus intrascranial like this. But when I injected 10 mil, 15 mil, more than enough. And now after that, get a nerve stimulator and ultrasound, open the gate. And because the treatment is not one fit all, they will have many options. But before to go to the option for regional anesthesia, I just will go to the nature, to the anatomy, to be in harmony with the nature. What about the anatomy? The shoulder joint is not one joint, it is a four joint. I will not speak about all this stuff. I will speak about the nerve supply of it. And there is not fixed nerve supply, it's different from one to one. And because of that, you can look for this study. It is just a few years ago, the anatomical and clinical study of suprascapular and axillary nerve block in shoulder arthroscopy. And they found many variation, and they studied again just to give more analgesia and more anesthesia for this patient. Again, pericapsular nerve group block for post-operative shoulder pain. And there is still running a study to see the anatomy we study in university is right and or deficient, and this is fixed for everyone or not, because there is a lot of variation in our anatomy. So the joint is four joint, as I tell you, and this joint is attached to each other by ligament and some muscle controlling the movement, and some muscle stabilize like rotator cuff muscles, and some muscle gives the contour and they give even the nerve supply for this joint. But I will not speak a lot about it because there is minor muscle here. But the real anatomy, how to know? The sensory come from cervical plexus with supraclavicular nerve, and this supply anterior part of the joint from C2 to C4. This came from cervical plexus. C5, C6, what's called the upper trunk, give a brachial plexus and give most of the nerve supply for the joint. Give a suprascapular upper trunk, posterior cord also from this branches from axillary. Minor sensory innervation, because you know the Hilton law in 1936, any muscle or any nerve passing the joint supplies the joint. Like dorsal subscapular, musculocutaneous, intercostal and long thoracic nerve, medial brachial and lateral brachial, and even many nerve passing this area, cancer, even subclavius nerve. So this is to show but we know that from the study that about 70 to 80% of the joint capsule supplied by suprascapular, and mostly 90% of the people don't have a skin innervation. And what's called lateral pectoral nerve can give a medial area for the joint, and axillary nerve can give a contributing in a major part. Upper dorsal subscapular long thoracic can contribute for this innervation. And a very easy way, just remember two important nerves, suprascapular nerve and axillary nerve. And if you block this two nerve, you can block about 80 to 90%, and it's very good percentage for the joint. And this study is try to found in dissected body how much every nerve supplies the area. And they found that the posterior superior quadrant or posterior quadrant supplied mainly by suprascapular nerve, and anterior or lower quadrant supplied by axillary nerve, and many of this area supplied by other nerve in dissected body, different from one to one. So can we get an well after shoulder surgery, or this is the end of life? Really, we can go, but this need to be professional in your career and also get more and more training, because nothing is easy. And what is the difference between general and regional anesthesia for shoulder surgery? You know, safety higher, more health, was more healthy patient with an general anesthesia. Regional anesthesia usually we make it for comorbid sick patient. Post-operative analgesia, but not necessary. Post-operative analgesia high score in just an general anesthesia. So low venous score and regional anesthesia, so more better for regional anesthesia. You have venous score less, you have more better outcome. Airway control with general anesthesia more better, because if you need just intubation during the operation, it will be very difficult. You change the position, you remove the wrap from the neck of the patient, and also questionable for regional anesthesia. Post-operative range of movement, usually poor, and sometimes severe pain with regional anesthesia. It was general anesthesia, whatever you gave, morphine or not. And also with regional anesthesia has improved range of movement and pain. Opioid consumption higher for regional anesthesia, lower for regional anesthesia, at least in first 24 hours to 72 hours. So just I will ask you this about this patient, and I don't need an answer, because I know there is no white and no black in our branches, and many people doing this different method for anesthesia, and it's safe. Just like when you go for some target, everyone take his way, which is in a professional net, and can give a good outcome. So I can't obligate anyone to do my way to get better outcome. So this is a morbid obese patient, have a 40 cigarettes per day, came for elective total shoulder arthroplasty. Saturation was 90% in the room air. She has Malambati 4, kyphotic fixed cervical spine. What is the type of anesthesia you chose for her? Just ask yourself. I don't need answer. So the answer now, to make a general anesthesia from the beginning, fiber optic intubation, and to get the chance to put a tube to secure everything, or to make, and this, I know it's difficult intubation, or to make here a regional anesthesia, but you have 10% failure and you need an emergency intubation. So what's your choice? What's your choice now? Thinking about it, and you know, there is no one answer. So about the systemic analgesia, everyone can do it, even the nurse. Easy, don't need more training. Multimodal analgesia can work. Patient need opioid for 3 days, for few days, and the risk of opioid. And the concern about narcotic use now, and about the narcotic crisis. And also the increase of incidence of cancer or persistent post-operative pain with systemic analgesia. In some studies show that. What is the advantage of regional anesthesia? Excellent pain control. We know that. Decreased blood loss. Yes, because this is, and many studies show that. Improve cardiac and respiratory function, because we don't make a muscle block, or just don't affect the dynamic of the patient, and don't use more drugs to affecting the heart or anything. Short stay in ICU in BACO. Ultrasound technique also improve the anesthesia and analgesia, and improve the time, dose, and complication, and the economy. So, but just remember, with this disadvantage for anesthesia, there is a failure even in the best hand. And if you become 95% success, you are the best. This is considered the ideal. Not long lasting, and we need some opioid, or to put a catheter, or to give liposomal bupivacaine. So not long lasting. Need a professional training program. Most of us doing a very great job in general anesthesia, but regional anesthesia subspecialty need another program or fellowship for many years. And we have a program here, and for 2 years and 1 year in America, just to go in America, and they become very professional as the fellows. Can't be used for every patient. Not every patient can do for it. Even some mentality of the patient don't accept it, and the patient must accept it, and to know the anticipation for what will happen in him. The need for equipment, sometimes expensive equipment like ultrasound, catheter, and other stuff. And also many questions about the regional anesthesia. What is the optimal dose? What is the optimal technique? What about everything? There's need and many research for that, and the research is running. So advantage of surgery under unconscious patient. If the patient is conscious, you control everything about your patient, you know, hemodynamically stable, and cardiovascular complication, blood complication less, avoid hypotension, you reduce post-operative nausea and vomiting from the drug and medication, faster recovery, efficiently saving the time to an institute, and also the economy of an institute, increase engagement of the patient in their care, and this is very important. But also, I tell you, this need a formal training. But what about regional anesthesia for awake soldier surgery? For sometimes I use for anesthesia or for analgesia or anesthesia or give a sedation or general anesthesia or regional anesthesia, but it is a very important part of our programs. So interscalene is a cornerstone for the block and the most studied block. Superior trunk block, 5-6 trunk, because the shoulder supply mainly come from the upper trunk. We don't need to block the lower trunk. Supraclavicular nerve block, now it's an emerging study about it and can work in a very good way and comparable to interscalene and less problem, because now all the time we're thinking to make another block away from the interscalene because they have a devastating complication when you just go away from the central nerve compartment. So supraclavicular nerve block, and also supraclavicular brachial plexus block. It worked in some patients. There is many study, a case study and case report, and case series. And axillary nerve, it worked also with suprascapular for shoulder dislocation and other stuff, and decrease analgesic requirement, and they help even post shoulder surgery. Suprascapular nerve, and even costoclavicular nerve for infraclavicular block. It worked in a good way. Because very near to suprascapular, you know. Supraclavicular nerve block, and the same, you found all the plexus compacted lateral to the block. So block for awake surgery, analgesia or supplementary for the regional anesthesia. We may need some more nerves because there is a variation everywhere. Or the patient given syringe in his hand infiltrating some areas. Long thoracic nerve, it is not a defect in you as anesthesia because different anatomy was different person. Long thoracic nerve, we may block it. Lateral pectoral nerve is very important. Musculocutaneous can give for the shoulder. Intercostal brachial, medial brachial. We can use Erector, Spiny, and paravertebral blocks. This is emerging study started from 2018 about that. And local infiltration and also subacromial subdeltoid, bursa injection, and the catheter. So can I ask you a question? What is the most important preventive measure for post-operative pain? What is the most effective method for post-operative pain? So really, the answer will be not to do operation. This is a silly answer because the patient still have a pain. So this is how to make the interscalene. But I will not speak about the technique and the stuff like that. I speak about the tricks when you make the technique. It can be done anterior technique, lateral technique, or posterior technique. Posterior technique more important because I can fix my catheter away from the surgical field. But I will just give you a tricks about interscalene. Take care. When you go for lateral technique, as you see this picture, you see this arrow, sorry. You see this arrow, you see my laser. This is the dorsal subscapular nerve. And here also the long thoracic nerve. When you go for lateral technique, take care about to injure this nerve because this is injured in many case study and case report. So take care about dorsal subscapular nerve and the trajectory of the needle, long thoracic nerve in the muscle, in the middle scalene, vascular structure, because sometimes you found a structure passing the plexus. So before to make any block, put a color Doppler to see if there is an artery or not, because all the arteries, vessels, and the nerve in the neck is black. So don't mix a black bubble in the neck. And typical vivid 6 nerve root, and don't go in between the nerve root. Just aside the nerve and inject. And the phrenic nerve, take care about the phrenic nerve all the time, because you know all the other techniques just to try to avoid the phrenic nerve paralysis, temporary or permanent. And this paper came from Korea. That risk of encountering dorsal scapular long thoracic nerve during ultrasound interscalene brachial plexus block, and take care about that. There is other block, as I told you, long thoracic or what's called Schritt's anterior blend block, like Muhammad Salah here. You can mix the long thoracic nerve infiltration in the area. It can inject here or blow the muscle. It can work for analgesia in some cases of shoulder and can help. And there is many studies showing that if you increase this one over the interscalene, you give more analgesia. And this is how to make the interscalene to inject here. What's about the complication? I get inverted. You know, this andrological complication, you know, usually you put it in the end, but take care about that, because if you are not professional, you can make a catastrophe. Cardiovascular complication, respiratory phrenic nerve paralysis, Horner syndrome, and there's a patient don't tell him about it, it will be a great problem to you. Superior laryngeal nerve block and the hoarseness of voice and aspiration, local anesthesia, systemic toxicity, intravascular injection, nerve injury, and vital structure injury like trachea. How to decrease that? By ultrasound, nerve stimulator, Minimize needle passes, don't make it like a fenestration. Awake patient to tell you if anything happened. Needle to nerve distance, you must make a distance to the nerve. Because even with nerve stimulator before, we put a nerve and a needle away half a centimeter from the nerve, and it was working very good. Injection pressure monitoring, and this is of questionable value. So the aim of argument about this block and other block is just not a victory. It should be usually progress to give more and more. And I just will give you some, I still have 20 minutes. So I give you some evidence about some blogs and some new stuff for research. So according to our study, marriage is the main reason behind divorce, and this is high evidence. But just remember, absence of evidence is not evidence for absence, because the evidence may be lacking because of less study. We need more study. So intrascalene block for analgesia and orthopedic treatment for shoulder trauma, single dose liposomal bupivacaine, and this is to avoid a catheter, and this is give a very good result, and they don't found a major devastating complication. Another, perineural dexamethasone, as I told you, in block, we need just to continue by catheter, liposomal bupivacaine, or to give narcotic. But they found if you give dexamethasone with bupivacaine in single dose, you may not need a higher dose of narcotics, and you know that you don't have a very what's called severe pain starting immediately as breakthrough pain. Again, I tell you extra plexus or versus intraplexus ultrasound guided intrascalene brachial plexus block. I told you don't go between the plexus itself, just lateral to the plexus, and inject it will soak all the area. You don't need to go in between the plexus to make a complete block, because this is a very bad practice and a complication happened, and you have more and more complications. This study shows that. Again, between intrascalene and suprascapular nerve block is as in meta-analysis is as visible alternative to intrascalene shoulder surgery, and no difference in between the two, except it may be in recovery for the first hour. You give more analgesia for intrascalene, but after that, most of the meta-analysis show no difference. Suprascapular block in obese population, analysis of 2020 block, and this is a new study, and showing that supraclavicular level block is working like in obese patient, working in 20 ml of local anesthesia in obese patient like intrascalene. Suprascapular and intrascalene block, they found no difference in analgesia. It may only the starting, as I told you, for first 2 hours or 1 hour in recovery, and the complications more and more with intrascalene. Comparison of ultrasound guided suprascapular intrascalene plexus block, all the studies showing that no difference. And why is this doing this study? To go away from intrascalene, because long time of study and research giving you more and more complication, like from this, from nerve injury, from all this stuff, you know. So now I just put you on confusion more than clearance, and no problem, because this is my picture when I attend this lecture first time, and there is no confusion because I told you there is no white and black. And why just thinking seriously about to get another block? Because in many cases, 100% incidence of hemodiaphragmatic paralysis associated with intrascalene brachial plexus block, even with ultrasound. When you injected more than 15 ml, and the higher volume you inject, you get the what's called phrenic nerve paralysis. You can tell me that the vital capacity decreasing 25%, and you don't have a major events. This is not in every patient, and in some patients they found that diaphragmatic paralysis become permanent, and they have a very impact on the patient, especially if the nerve is predominant. So thinking seriously about to make another block away from this paralysis, because there is many case report, and many case report even need a ventilation. So permanent diaphragmatic paralysis after shoulder rotator cuff surgery is not only by anesthesia, it may be patient related from the beginning, surgical related, anesthesia related, but all the time they blame, if you found anything, just wait and they blame anesthesia. This is a problem. Especially in our countries, we don't have what's called good or justice investigation. So most of the studies showing that we're thinking seriously about a new block because phrenic nerve have diaphragmatic problems, and also can testing that after block, you can find that vital capacity decrease, and also maybe diaphragmatic movement silent. But thinking seriously about another nerve, we make a suprascapular nerve block. And we have many techniques, anterior approach and posterior approach. And they found the anterior approach is more effective. And most of the time, if you make a supraclav, this is the most lateral branch and just under the inferior below of homohyoid. And usually need a 3 to 5 mil, and it's very superficial as you see. But also you can make it posterior here, but some of the branches supplying the other area can be missed, but it can give a very good analgesia. This is a fossa for the scapula, and this is transverse ligament, and here we found the nerve and sometimes the artery outside or inside. But just remember, there is many variation, as I told you, many variation in the presence of the nerve, and the nerve sometimes going through the bone. And if you lose the nerve, you can go for spinal glenoid notch. You can posteriorly 1 centimeter after the spine of the scapula, but here you miss the AC joint innervation. And this is what's called anterior approach. I can see this is the most lateral part of the one, and you see that here the inferior below of homohyoid is more black. It's anterior approach and posterior approach and suprascapular here. Yeah, but really in real life you don't see this arrow or name, but you must know that is the most lateral one is the one. And here randomized control study to show that no difference between intrascalene and because it's gold standard and what's called in analgesia. This is a suprascapular nerve. Again, if you need more analgesia, you just go for the axillary nerve, and can be blocked ultrasound by longitudinal technique or transversal technique. And the landmark here, circumflex artery, you see the artery, around the artery, you found the nerve plexus, or just the nerve you injected 5 to 10 mil, you can make a block for it. Here the axillary and circumflex, and here also the transverse technique, you can make an oblique technique. The landmark here or the orienting structure is the artery. Cervical plexus block, as I told you, this is you can block it as C4. How do you know the C4? Most dilated part of the artery when you give to internal and external carotid. And you can see the pretracheal fascia and the wedge shape for the wedge shape here for the sternocleidomastoid, and injected down. Before it was an C6, but now they found that if you make it an C4 is more better. And usually the biggest nerve here is greater auricular. You can see into vision just a subcutaneous and down to the muscle. I just will not go for the technique, but mostly you need just to shoulder as a shoulder sparing technique. Another block to go for the upper trunk, because this is what we need, C4, 5, and C6, and this is what we did usually in foraminal stenosis or spinal canal stenosis and cervical nerve root. And it's called selective nerve root block, injected around the nerve root. And instead to injected a few mil, 2 mil, 3 mil, and corticosteroid, we injected about 10 to 15 mil about the upper trunk. And this is give very good what's called analgesia and decreasing the incidence of phrenic nerve problem. And the upper trunk is a safer shoulder surgery, but safer for a trained one, and they give an profound analgesia and anesthesia and minimal amount of opioid, sparing the diaphragm. But no one of this block can get a 100% sparing the diaphragm. And here you can see the anterior tubercle, posterior tubercle. This is the C6 when you found that, C5. And this is how can you inject, but take care about the radicular artery here, because here the deficient blood supply for the spinal cord. And here C6, this is C7 when you found like a bit shear appearance and vertebral artery, take care. This is a monitor of the neck. So you need to inject it here only. So, and this is, this is a study about serratus anterior block for interest can improve the quality of anesthesia of arthroscopic surgery. So I told you a lot of debates about everything, and we are still in infancy of the research. But if you know 2 to 3 technique and you use to tailor on your patient, you can help your patient all the time. Whatever you make it general sedation, regional was that thing. The superior trunk block, again, pictures. Superior trunk block, how can you decide to make this block? And you need a lower volume. And here the clavicular technique, which is a new technique for what's called medial technique for infraclavicular block. And in this area, just below the middle of the clavicle, you found the nerve is compacted here, and there is only one fascia around. So even the catheter is more effective. And here you inject, because this is like a tunnel. It can give a denser block, less phrenic block, and many cases report about using in analgesia. There is many other nerves, lateral pectoral here. When we can pick one, you found an descending branch of thoracoacromial artery. You can decrease, you can inject about 7 to 10 ml, more than enough. Serous anterior Bling block, as I told you here before, and I show Salah picture. So in some cases, musculocutaneous give a very good contribution for the shoulder surgery, and there's many some studies showing that if you make it more, it can give you more and more. But I think 70 to 80% of analgesia is more than enough, and if you give auxiliary, it can give 10 more percent, more and more. The new thing, what's the new block, which is called the Erector Spiny Bling block, which is a one fit all. This block one fit all, because you can make it cervical, thoracic, lumbar, even sacral in some study. And for me, in chronic pain, I use him a lot, even my facial pain, transection of spinal cord, even in some complicated cases of field back surgery, and if you can't make a more injection, even in sacral area. So it is like a one fit all, and the mechanism of action is just to go like an epidural. If paravertebral considered like a spinal, it's like an epidural, going very slow, and don't give usually motor block. So post-operative pain adequately managed by what's called Erector Spiny Bling block, further articular anesthetic infiltration, and 70% of patients report moderate to severe pain. And this patient getting completely what's called the pain score was very low. Multimodal analgesia also used on all this patient and given a very good block. So Erector Spiny Bling block is a valuable intrafascial Bling block as a part of regional anesthesia, maybe superior to local anesthesia infiltration, but this need more study. And this is my normal practice, because up till now I make more than 1,000 Erector Spiny in every type of blocks, and even something outside the box. And every day I found what I did, I come and study to show that. And also, this is what's called the idea behind sparing this phrenic nerve, because don't give any motor block and give not nerve block. So Erector Spiny Bling block for proximal shoulder surgery, a phrenic sparing block. So with this case series, because it's starting research, indication of Erector Spiny Bling block post-operative surgery can be used. There is a cervical don't go up, usually C7, C6 maximum, and don't inject high volume. And this is an old thing, because before we make a deep cervical plexus at C4, around C4, and injecting around the nerve, because there is a fascial plane in this area. And can you see here, this is a C7 articular process we injected here. And showing that phrenic sparing technique, and this is how it works. This is under CT, when you injected a dye, you see how it works, just going for even the nerve root. And some cases you can see it just going to the epidural space and even to other side, but it gives very slow distribution. It can give more time after paravertebral till 8 hours. Can give you the similar analgesia to Erector Spiny, but after 8 hours, Erector Spiny more better, give it more anesthesia. And it's like an epidural going very fast. So the potential advantage of Erector Spiny for upper limb surgery, it is less risk of nerve injury, blockade for intercostal nerve, but this need more study. Less Horner syndrome and the hoarseness, but it happened because I see 2 cases with my case. Catheter placement, you can put a catheter, less risk of diaphragmatic paralysis, because very rare to affecting with normal dose for analgesia the motor nerves. Motor sparing cervical nerve blockade can be done. So this is a study showing that the best analgesic regimen for the shoulder surgery, and the answer is there is no best. Many studies can show that multimodal analgesia is the best. Intrascalene can be used, and many other type can be used. As I told you this is an phrenic nerve and complication related to dose. And this is what's called a study showing that 20 ml versus 5 ml. They found that more comparable analgesia with the complication was 20 ml more and more. So I just will go fast, because there is other study done by surgeon about infiltration for the shoulder surgery, and they found very good analgesia, but the problem area is hyperemic and absorption very fast, so the complication higher, and the analgesia can stay for 2 to 4 hours maximum. And this is a case report about suprascapular nerve block or supraclavicular nerve block and this is just a case series. And because of that, there is a nice Zimican joint replacement, primary hip, knee, and shoulder Zimica guideline. And this guideline with me, anyone just need it, I will send it to him. I'm scared because some of you are just sleeping or doing another thing. And this is a problem of distant learning. And I know that I take more time, but I get a permission from the organizer. And this is not an over, but some of you wanted to go to do something and waiting for me to finish like this cat. So again, I remind you, the case description, this is a morbid obese, 40 cigarettes per day, elective total shoulder arthroplasty, saturation 90% in room air. She has Malambati 4, kyphotic fixed cervical spine. What is the type of anesthesia you choose after you know all this stuff? And again, I will ask you as a Renee, regional anesthesia for 6 years old patient with hypertensive diabetes, coronary artery disease coming for shoulder arthroplasty. List the optional regional block for shoulder surgery and their complication. I think you can do now. Identify way to avoid complication, just I show for you. Propose surgical position for surgical anesthesia and its consequences. I tell you this is the most important. Formulate post-operative being option, and I think you can answer all this question. But if you got an MCQ, it will be a little difficult. So what about my sweet conclusion? Because I found all people just get frustrated from the time. And so conclusion, visual appearance, position carry a major risk, and this is a very important. Updating our anatomy knowledge. If you go for any book, new book for regional anesthesia, you found he's showing the updating anatomy, even the variation, study about the variation in every organs. For example, lateral cutaneous nerve size, the variation is 42%. The supraclavicular brachial plexus, the variation is 28%. So 1/3 of the case, you don't find the normal anatomy, you know. And the anatomy can change by position. So learn a new block, because what you study in anatomy, it was an what's called an cadaveric position or just an anatomical position. Learn a new block all the time. Shoulder surgery associated with severe pain, don't ignore that. Regional anesthesia can be used to give anesthesia or analgesia. Interscalene block is still the gold standard because it is not the best, but it's the one which killed by study, but have a devastating complication. Selective peripheral nerve root and nerve root block maybe and have a future in the research. And the operative pathway should integrate patient education, intraoperative multimodal analgesia, don't depend on one modalities. Regional or general anesthesia, safety is paramount. I don't care. Safety is very important. Ready for complication all the time, to discover and to treat, because if you don't discover, you can't treat. We don't know peripheral nerve block with ultrasound become more severe than before or not, because we need more study and more meta-analysis. And remember, the absence of evidence is not the evidence of absence. And we still remain in the infancy of the trial, because most of this trial in 5 years, what all the people bring is 5 years ago, mostly 5 years until last year. So publish is one side of the coin. Also take care about when you read any paper and to take it for practice without more study, because, you know, this is one side of the coin. If the researcher is not professional, it can give you a different result if it's professional. And all the time, you don't ask about this researcher is professional or not. So we need more answer to many questions about the do's, what is the best technique for every procedure, or procedure specific. And I ask you and myself to put a guideline for your hospital about preoperative, intraoperative, post-operative. And if you do that and the patient get a pain control, he will be happy and you will be happy with this patient. But really, life doesn't change better by chance, but it changes better by change. So thank you very much. And any question, and anyone just need anything, any help, any questions, you can just contact me with this personal email, business email, and also the my phone number.
دكتورة صفاء مش معانا ولا ايه؟ I didn't see any question from any person yet.
Exactly the problem of distance learning.
You answered all during your talk.
But please, Dr. Yasser, بس.
Yes.
I just summarize.
Yeah. Yasser, what is your technique? What is your experience? Yeah. You mentioned a lot of block.
Yes, yes. Really, because we have a regional anesthesia training program, we do all these blocks. And we selected according to the patient, and according also sometimes we pushed by education. So if you have 2 or 3 blocks, can give the same result, and the trainee want one of the blocks because he make another blocks, I can do it. And but most of the colleague here and the team here doing some sedation was for example intrascalene posterior catheter, or if it use it with heavy sedation or just with general anesthesia or laryngeal mask. Usually we put an because most of the surgeons don't like to come near his wound, and they claim that infection coming from you. So what we did, I make an axillary and suprascapular. This is different from surgeon to surgeon, case to case. So if he don't like just to come near his area, I just make him an suprascapular, posterior anterior approach, or with axillary. And unfortunately, we try to bring a liposomal bupivacaine because you know that sometimes we put a catheter. We have many cases. Just we have the head of ambulance here who was collecting a patient from car accident, and a car coming to hit his shoulder and have a problem. And most of the time he make a surgery, many surgery, and put him a catheter to go home with this infusion. So we can use a catheter in many patients. Some patients we can make an peripheral nerve block if the surgeon don't come to his area. We can put an intrascalene posterior, and in obese patient sometimes we make an suprascapular, supraclavicular nerve block, and just give an 25. It worked most of the time. Because as I told you, sometimes you have a variation. Some patient worked with it in a good way, and some patient needs just some infiltration of the surgeon. Take a 10 ml for lipovicaine, 0.35%, and orobivicaine, and make a more infiltration. We have all this one, and really we don't have an guidelines up till now because you know the research is running, and you can't make a guideline to change every day, you know. But we plan now to make just guidelines, or just a guideline for the block to start at perioperative, what we do for operative education and all this stuff, and the treat the pain, and the intraoperative what we do, and post-operative what we do, and we'll try to make an soon, inshallah, this guideline.
Okay, Dr. Asafaz, there is some questions we may ask this for Yasser.
Yes. دكتور ياسر بعد اذنك حضرتك بتقول ان احنا ممكن ندي سوبرا كلافيكولار واكسيلاري and you put a laryngeal mask for the patient.
Axillary nerve, not axillary plexus block. Yes.
Axillary nerve I know. وسوبرا كلافيكولار وبعدين هنحط له laryngeal mask عشان لو يبقى disassociated من السيرجيكال فيلد، مش كده حضرتك بتقصد؟
Yes. Sometimes we do that.
Please.
But this is not not a routine for every case. Yes.
I'm afraid لو أنا هحط في الابنورمال بوزيشن ده laryngeal mask I will be afraid.
Usually if you put a sedation without, you know, that we don't play with black and white. Anything can happen. Even if you make an totally awake, anything can happen. You know, we have a case here, he get a stroke. And was working very good. After 2 hours, the patient get a problem. So everything have a pro and cons. But in many cases, in hundreds of cases, we put a laryngeal mask with sedation, and it works very good. Especially if you have a third generation laryngeal mask. Okay. I think you have this third generation.
No.
Ice gel. Ice gel. You know the talent of ice gel, when you put it in the anatomy of the patient, he make an by heat of the patient. He makes
that. We accept the donation. You can bring some. We accept the donation.
Usually anything can happen, but you know that if there are remote possibilities, it's okay.
Okay, just for sedation, this is we can use nasal oxygen cannula with this.
You can use anything, nasal cannula, mask.
If it operated promptly, if the regional technique operated promptly, and the surgeon would like to disassociate his patient from the surgical field, is it nasal cannula more enough, or should have? Okay.
Yes, it works most of the time, because most of the time we give a very light sedation, or just whatever propofol. Some people give dexamethasone, You know, it works. Yes.
I suppose. As regard the liposomal bupivacaine, do you use it, Dr. Yasser?
I use it in Saudi Arabia. It was in other hospital, but when I came here, I don't found it. But one of our colleagues came from America here to make an locum for spine surgery. He bring a lot of a big amount for us, and he was using routinely for spine surgery. And because you know that the talent of this liposomal bupivacaine is can stay from 3 to 5 days.
Yes, I know.
And all the comparative study between the catheter and liposomal bupivacaine is not cheap, is expensive. But if you compare after 5 days, you found more cheaper than the catheter. If you get infection, if you get, and you know that when I was speaking with you, it was out of box about a few months ago from America, and at that time is about 10 million American use it. Patient. But now it's approved for interscalene, approved for many blocks, even FDA. And I think sooner when other company will do it, it will be a promising thing. But remember that this liposomal bupivacaine, it's not working immediately. It takes about 12 hours to 16 hours to wear. So you can use bupivacaine with it, and xylocaine is not efficient if you use it with it, because xylocaine can work for 4 hours, 5 hours. So there is a very big gap. But you can use it with a regular or isobaric bupivacaine with liposomal bupivacaine. One is starting and the other continue. And also the toxicity, all this stuff is not a big problem because they slowly release.
As regards the catheter, so continuous technique, this catheter, which type of catheter you use, Dr. Yasser?
We have two types of catheter. We have arrow, which have the enforced wire.
And special one for this technique, the special one for this.
There is a catheter for regional block, not an epidural. But I tell you something. We have about 1 month or 2 months have a deficient with this catheter. So we use an epidural, and I don't find a big difference, you know. But you know that the other, and usually you put it 3 to 5 mil inside, and you can check the catheter by ultrasound to adjust it. But now, and I try to make a big tail catheter, because the fixation, whatever you do, and movement of the muscle, you can't stay for a few days in a position. So now there is what's called the big tail, like an double J. And you put the catheter and make like a big tail. The fixation is 90, all the study shows 90% can stay after 3 days in a position. So we'll try to bring this catheter soon.
Okay. Dr. Yasser, my last question, do you have some problem with the patient on anticoagulant with these regional techniques?
Yes, sure. Usually we don't have, as I told you, black and white. But if you ask me, for example, you have a patient, as INR was 0.8, and we do that, 1.8. And if you do anything away from spinal, for example, you will kill the patient, you know? So I make it or not? What do you think? Okay. I make it. I do it. And most of us can do it. Don't restrict it to one INR1. And you and me and everyone make it at 1.4 and 1.5 if the patient is okay. But you don't go for a difficult patient and obese patient, and it will be difficult. For example, regional anesthesia. I make a case 2 days ago, the INR 2.2, and the cardiologist refused to do anything for him. He tell me if I decrease it, I will kill him. So I make it. I make a look below knee amputation, renal failure, and so I make it because I have this is a compressible area, but I can't make, for example, lumbar plexus block for him, because I can kill him. But for a compressible area, I can do it. Okay. You know, and as I told you, this if you have a straight way and you have a lighted way, but this way you have a problem inside. I can get a side way, but this is not the routine technique. This is just an exceptional. Okay. As I told you, just no black and white, just you balance your technique.
Dr. Yasser Zaghloul, اتفضل. You have 6 questions in chat box.
Dr.
Yasser Zaghloul, you have 6 questions. You have 6 questions in chat box. Dr. Yasser Zaghloul.
You can see it.
No, you, just you.
Yeah, about there is some question about the auxiliary nerve block. Yeah, but he asking about the best technique, how to do axillary nerve block. Is it directly related to your talk?
You know that if I can remove my clothes, I will show for you in a good way. But here, if you look for your deltoid here and triceps, and between the deltoid and triceps, there is a groove. You can feel it. This is a groove. Just put your probe transverse in this groove. You will see an artery, and you will see just above the bone. And this artery is the same like when you go on for a radial block down, but radial is down. You can, because this artery and the tortuous and the nervous tortuous, so you can manipulate your probe. Some people get transverse, you see the bone and see artery and pulsation between artery and the nerve. This is a transverse. But also you can put in what's called an ASIS technique, just to put here in this area between the deltoid and triceps, and you can see immediately the artery and the axillary nerve.
All right.
There is other technique, anterior technique, but this is the easiest one.
Yeah, and these questions, if the patient develop Horner's syndrome, is it any management for that, or just to wait for the wean off of the medication?
The management is prophylactic. You must tell him. If you tell him, you can feel an hoarseness of voice and Horner syndrome, because this is what we see. If you don't tell him, you have a great problem. The patient not stop speaking and think that's a great problem, and his family until he resolve. But if a Horner syndrome, don't do anything. Just if he knows that, and we tell him that after 3 to 4 hours or 5 hours, it will be resolved completely. And the explanation of that, it can some fluid trickling for the this ganglia, and if you discuss with him, no problem. But if you don't tell him, you have a great problem.
All right. And the questions, I think, from Muhammad Abdul Shafi, we have experience with interscreen without GA or only with sedation. Can suprascapular cover the anesthesia level required without GA? Is it enough, the block, suprascapular block?
You know that I tell you what is in the research. I don't tell it that like fixed the science, but in the research there is a mini case series about that, and we have 2 cases. We did 2 cases. We inject about 28 mil of regional anesthesia, and it worked for supraclav in obese patient. But the surgeon was even without sedation. We have a syringe was bupivacaine 0.25 20 mil. And use it when just a patient start to feel. It can work.
Yeah.
But this is need a more study, because you know it will not just an effective like it may be effective, I don't know, but it need more study, because all what you see is a case series and experience for someone. We need a randomized control study. We need meta-analysis about many cases, you know.
Yeah. When you are using interscreen block, yes, you are using catheter or just some one injection, bolus injection?
This is a very good question, but this is according to the situation. For example, arthroscopy, it's not so painful for many days. I can just use an interscalene with adjuvant like an dexamethasone or just a dexamethasone. And especially there is a study showing that if you give a dexamethasone, it can continue, give it more time, and also don't give a severe pain after finishing, you know. But if the patient is extensive surgery, and the patient will stay in hospital, because there is a decay surgery, so inject 1 injection and the patient left. But if there is a total arthroplasty or extensive surgery, usually we put a catheter for 3 days, 4 days.
All right, yeah, because B. Muhammad, he mentioned that there is a case report of intrathecal migration of the intrathecal catheter, interscreen catheter. Interscreen catheter, intrathecal migration causing fetal response.
This is a case. This is a case report. Yes, and there is also with a needle only. With a needle make a spinal cord injury. Some people just during the last time going for a needle, but a needle only without a catheter, and the framing and going to the other side make a nerve injury. It can happen. But if you trained enough with ultrasound, it's very difficult to happen. But most of this complication happen without ultrasound, and the very little case report happen with ultrasound. You know.
Yeah. And when you combine the nerve stimulator with the ultrasound, or only ultrasound without nerve stimulator, yes, sir?
You know, I started ultrasound 2006, sorry. When the machine was very bad, like an old TV, when you just adjust the antenna, give G, and like this. And we stay about 6 years also, 6 years using a nerve stimulator with ultrasound. 6 years, I never use the ultrasound alone. But with advanced technology now, and especially with Sonosite, GE, a very good machine, we have a very good machine. For about now, from 2013 or 2014, I never used nerve stimulator. But most of our colleagues, if you have a very deep structure like sciatic, very deep, and I'm not sure about it, sometimes he can use this nerve. So this is not an accepted routine for everywhere. But some people just still not sure about the nerve, just using, especially in deep structure, he can't see, he don't have a good machine, don't have an experience. But for our team now, you know, even for my fellow, I don't see the nerve stimulator for a few years now.
So basically, you are using ultrasound,
ultrasound,
right? And in some maybe few cases, you may need to add the nerve stimulator.
But I don't use it, and all training program for a few years, 6 years, 7 years.
All right, yeah. There is some no questions more, but just I want to ask about the usual protocol for post-operative analgesia in your cases.
As I told you, we don't have a fixed protocol now, and I'm thinking seriously to work in with my team about the protocol, but we don't have a protocol. Why? Because we have a very big, bizarre surgery, from a very mild surgery to extensive surgery, and we need to make a protocol to be flexible for all of this stuff. And also we have a very difficult surgeon dealing with a difficult surgeon. I remember a few days ago, the surgeon refused to give him a block, and we give the patient 30 milligram morphine, give him everything, and the patient is still screaming. So he left home. I call him from home. I tell him, please come to see your patient, because the patient can't stay like this 3 hours in recovery. And the patient is still screaming. He tell me, give him something. I give him everything, but you don't agree with my management. And they tell me that just to give him anything because he don't like to come, you know. But this is different from area to area. Now we're just working on protocol, but protocol must be flexible because you don't deal with one disease, not one disease. It is many things to be in the shoulder, some very painful and some severe and some less painful. And you know, the manipulate according to the surgeon. You know, some surgeon accepted from the beginning, some surgeon not accepting.
Is it day case surgery, or the patient should stay in the hospital overnight?
Some cases day case, some cases like arthroscopy, especially with infection with staff, with other staff, arthroscopy, even clearance for the, and some cases of diagnostic arthroscopy. This is going home immediately, just to give him one shot. But in some cases, they can stay in hospital for 5 days, and we'll put a catheter for that.
Okay. There is 2 questions more. One from Mahmoud Abdul Qawi, and he's asking about about chronic pain. And analgesia implants. I don't know what he means, analgesia implant.
You know, if you ask about chronic pain, I have a presentation. Complete presentation about chronic pain, and if you permit me to speak about shoulder for people interested in chronic pain and how to examine what you found, how can you treat, and how can join another treatment multimodal technique with other specialty, what is the surgical procedure. I have a presentation ready. I did it because we have a workshop for pain, 4 workshops per year, and I make this, and if you need it, I can just, and the problem of my presentation, if you like it, it will be very heavy, about 50 megabytes, because it's animation and stuff like this. So if the club, what's called the Menoufia Club, permit me, I just will make it after any time you like, inshallah.
All right, And also about the use of liposomal bupivacaine. You have any experience in it? Liposomal bupivacaine?
Yes, few years ago I have experience with it, and it was very good.
Okay. And also he's asking about if you are using the ultrasound image, do you need to do some physical examination, palpation, and to track the nerve, or no? Or ultrasound is enough?
This is a very interesting question. When I go for an exam for IDRA, he bring me a patient like a very tall student, like 48 kilogram, and asking me about to make intercostal nerve by ultrasound. I tell him I can see the artery here pulsating. You know, it was like even I don't need an ultrasound, but you know, it is not a shame to feel everything before you put a probe. Not a shame, because this is orientation. But this is can guide you, can help you to guide, to see the orientation, to put in, for example, when you injected, for example, AC joint, I put my finger first and put a probe. It is not shame to use that. And you must use all the data in the box to get more information to guide you for the better outcome.
Yeah. And another question from Wasim iPhone about the subsurgeon. The concern of some surgeons about the motor block with interscalene injection. How can we manage?
This is not the concern of the surgeon only, the concern of the patient also. Some patient, if he feel a numb limb for a long time, he get irritated. He don't, and even sometimes tell me that I don't need this block, but he don't know what happened if I remove the local anesthesia and how he's screaming. And some people refusing, and after screaming, ask again to do that. So this is what I'm telling you, Dr. Yasser. And because there is some complication for interscalene, most of the research is searching for another thing, not just an complication, also the motor block, because sometimes the surgeon want to examine his patient after that. So in some areas, we can decrease the concentration if we're obligated to use this block. But in some area, we can use what's called the Erector Spiny Bling block, and we use it in chronic and acute pain, and it works very good, really very good in acute and chronic pain, even for shoulder pain. So because of that, we're thinking seriously to go away from this interscalene. We can use an axillary, we can use an suprascapular. It can give the same result without this motor block.
All right. Thank you so much, Yasser. Just I want to ask you the last point to summarize your talk in 1 minute exactly, not more.
For me?
Yeah, take home message, yeah.
Take home message.
In 1 minute, 1 minute, yes. Not more.
Whatever you master, general anesthesia, regional anesthesia, do what you master, and don't change your practice until you become trained. And every method have its own complication and its own advantage. Don't do it without what's called a thorough training. Whatever you do, you must search for the effect and the side effect of everything. And researching coming in the future to give you a better answer for all questions. Thank you.
Yes, yeah, okay, yeah. Thank you so much. Thank you for Dr. Safa for her caring this very nice meeting. And we will meet you again after 2 weeks, inshallah. And hopefully we have more development, more new idea, and more young anesthesiologists sharing us, inshallah. Dr. Safa?
Dr. Yasser, I have one word away from this. I'm thanking you very much, so much, because I like you and I like to listen from you. And you are my friend. And I thank you, Dr. Safa, and thank for all junior staff or attendee or our colleague in presenting one. I'm just proud to be between you, and they are lucky because we don't have all this propaganda and media when was a resident and other, was searching for information from far away, waiting for 1 month to get it. And you must use this opportunity to get to be more and more better than us. Thank you.
شكرا لحضرتك يا دكتور ياسر، شكرا جزيلا، شكرا لحضرتك. ان شاء الله نتقابل فيزيكالي ان شاء الله، وحضرتك توعدنا بورك شوبس، وان شاء الله المحاضره بتاعت الكورونيك بين نحضر لها قريب باذن الله، ونبقى ان كونتاكت مع حضرتك.
I'm ready ان شاء الله.